To get started, we have Dr. Thomas Lodi with us. Our first speaker, he's a visionary in integrative oncology, and beautifully, he blends cutting-edge science with his compassion to redefine cancer care. What really set him on this path? Early in his medical career, Dr. Lodi encountered patients whose cancer treatment felt incomplete to him. It was focused more on treatment on symptoms rather than root causes. So, driven by a desire to do better, he pursued integrative approaches, combining conventional medicine with functional therapies. Today, as a founder of Oasis of Healing, he empowers patients worldwide to take charge of their health through programs like Stop Making Cancer course. So here we have him to reimagine cancer care through the functional medicine lens. So please welcome Dr. Thomas Lodi. Over to you, Dr. Thomas.
Okay, come.
Yes, Dr. Thomas, you can get started.
Can you see me or hear me?
I'll get your background removed. Yes, we can hear you.
Cannot see me, huh?
Yes, just give a second.
Does it come on?
Just a minute. Sorry
Okay.
about this. So, Dr. Thomas, just give us a minute and we'll get this fixed.
All right. And then I
Yes.
just share, right? I can share.
Yes. You can start your screen sharing. Everyone, we'll get started in 2 minutes. All right, so we have the Dr. Thomas, your screen is visible.
Oh, you can see now, huh?
Yes, yes.
I don't see. Oh, but okay, you can see me, right?
Um,
Yes, sir. We can see your screen. You can start.
Oh, okay. So you can see my screen. Okay, beautiful. All right.
Yes.
So, yeah, integrative oncology, which is I've been practicing now for about 23, 24 years. Trained in internal medicine in New York, Columbia. Okay. So, I want to point out here that this was published in the Lancet, showing that high-income countries, cancer has taken over as the leading cause. As you know, it has always been traditionally that it was cardiovascular disease. So in the high-income countries, which I think is 21 or 26 countries, it's now the leading cause, whereas in the middle and lower incomes, it's still cardiovascular as the leading cause. So now, You went over a little bit about the burden, but basically, 1 in 5 men and 1 in 6 women will develop it in their lifetime. Now, this was prior to the turbo cancers that we're seeing now, which, by the way, don't take 8 or 10 years anymore. They happen very quickly, and we're seeing now. I had an 18-year-old female with colon cancer. I had a 23-year-old woman with ovarian cancer, stage 4. This just doesn't happen normally. Okay, and prior to all that, the turbo cancers, 1 out of 6 deaths in the world was due to cancer. So if you want to talk about a pandemic, there it is. Now, just to show you real quickly, in the U.S., 1 out of 2 men and 1 out of 3 women. That's pretty crazy. So therefore, the question is this: if it were genetic, and 1 out of 2 men and 1 out of 3 women, then we should all have at least one grandparent with it, right? But we don't. In England, 1 out of 2 men and 1 out of 2 women. Okay, now in India, it's much less. 1/4 the rate of the United States and 1/2 of the global average. So this is good news. So keep doing whatever you're doing and don't follow the US. Cancer is not ethnic and it's not genetic. When someone migrates to another country, they bring with them the disease profile of their country. Their children now have the disease profile of the country they had migrated to. Therefore, how do we explain that in terms of genetics? Now, have we made progress? Richard Nixon, 1971, war on cancer. Yeah, we're going to war on cancer, war on terror, war on everything, war on drugs. Anyway, heart disease in the last 60 years. Now, this is data from the CDC. Okay, 1950 to 2010, that's 60 years. We see heart disease has come down. Cerebrovascular disease has come down. But infectious diseases and cancer have not changed in 60 years. So I would like to know how we are doing. Why we would think we're doing so well. So what is cancer? We have to talk about that first. Okay, so summarizing in a few words, we all know Otto Warburg. He Nobel Prize for his discovery of what cancer actually is. And he said, in a few words, the prime cause of cancer is the replacement of the respiration of oxygen in normal body cells by a fermentation of sugar, period. So here we can see on the left, we've got normal differentiated tissue, and we can see that in the presence of oxygen, it goes through the glucose goes into pyruvate, which enters the mitochondria and goes through oxidative phosphorylation. All right, about 94% of the energy is produced in the mitochondria, 6 in the cytoplasm. In the absence of glucose, it goes into anaerobic glycolysis. Okay, now with cancer tissue, regardless of whether or not there's oxygen or not, it goes 85% into glycolysis or fermentation, and only 5% into the mitochondria. This is called aerobic glycolysis. It's the Warburg effect. All right, now, very important, essential. If you're going to treat something, you need to understand what you're treating, okay? There is no specific gene mutation or chromosomal abnormality that is common to all cancers. So what's the difference between ovarian cancer, breast cancer, colon cancer, liver cancer, pancreatic cancer, brain cancer? Location, period. Okay, and the reason they act differently is because that cell has different functions. The liver cells do different things than kidney cells, all right? And they have different drainage patterns. So that's why we see differences. But the fundamental thing that allows you to diagnose cancer is when the pathologist looks under the microscope at the tissue and sees that there are morphological changes. Why are there morphological changes? Why does the cell look different? It looks different because it has changed its function. All right, we know form and function, right? Anatomy, physiology are mirrored, are two sides of the same coin. Okay, and this aerobic glycolysis with lactic acid production in the presence of oxygen is the Warburg effect, and this is why PET scans work. Okay, just real quickly, we all know that if you get 2 ATP made in the cytoplasm normally, and you get 36 from the efficient metabolism of glucose pyruvate, a total of 38 ATP for every glucose molecule. Okay, now in fermentation we only get 2. Therefore, we have 19 times less efficient at energy production. So how's the cell going to survive? It needs to have 19 times more fuel. Very simple. Okay, Now, all cells have an energy requirement, okay? It's called the delta G ATP. It's the amount of energy a cell needs. And that cell, if it's an elbow cell, a red blood cell, a tumor cell, or a rapidly beating heart that's in a marathon, it still needs the same amount of energy. Average is minus 56 kilojoules per mole. Period. That's it. So that's what we need. And that's the most fundamental thing. And the reason that's so important is because about 53 to 55% of the energy that a cell produces is merely, I mean, not merely, but is to maintain the sodium-potassium pumps. And why do we need to maintain that? Because that gives the cell existence. It now exists. Now that it exists, it has a form. Now it can do its job, whether it's a liver cell, kidney cell, heart cell. But number one, we've got to have the energy to have a separate, independent existence. Okay? So now what happens with this continued glycolysis going on inside of the cell stimulates a retrograde response, which upregulates everything to improve, to make sure that glycolysis and glutaminolysis will allow the maintenance of the required energy, which is minus 56 kilojoules per mole. All right? That's it. This retrograde response activates MYC, RAS, HIF1 alpha, mTOR, all of these pathways that we consider that are necessary for cancer to exist, right? That's what happens. So that's what it's doing. The retrograde response, the epigenetic changes are changes that are required to maintain the ability to produce enough energy so that the cell can function. Okay, even the loss of p53, which we see in most cancers, right? Why is that? Because it switches metabolism from the mitochondria to glycolysis. Okay, so all of these growth signals and unlimited ability to replicate are merely to sustain glycolysis and glutaminolysis. And if you don't believe it, go back and review your biochemistry. Okay, now, so what do we have? We've changed operating systems. We went from Mac to Windows. Yeah, that's what happened. We changed operating systems. So how did we do that? By making epigenetic changes, including things like downregulation of P21, P53. These are all tumor suppressor genes, right? Okay. Now, if these were mutations, they wouldn't change. Because if you have Down syndrome, I don't care what I feed you, I don't care what IVs I give you, you still have Down syndrome. That's a mutation. However, with these things, I can give you lots of brassica vegetables, and we're going to restore P21, P53, P10. Look it up if you don't believe me. And I'm happy to share all the research I have, okay? But I'm not saying mutations don't occur. They do occur, but they are due to the genomic instability of continued glycolysis. So they are, as Thomas Seyfried calls them, a downstream epiphenomenon. They're not the driver of the car. They're sitting in the back seat. All right? Now, mutations can stimulate this shift from Windows to Mac or Mac to Windows. But it is always secondary to the metabolic changes. And let me give you an example. We talk about the toxic effects of ionizing radiation, right? All right, so what happens with ionizing radiation? Okay, we wind up getting, the damage is to the mitochondria, primarily. Okay, and when there's damage to the mitochondria, it must shift to a glycolytic metabolism in order to survive. Okay, you have increased glucose uptake, enhanced glycolytic enzymes, which allow fermentation, and of course you wind up with increased lactate production and an acidic tumor microenvironment. But again, it wasn't due to a mutation that caused it. It was due to the damage of the mitochondria, which changed the metabolic. Okay, now I want to real quickly talk about psychoneuroimmunology. It's a field that has emerged in the last 10 to 15 years, okay? And basically understand that words are the scaffolding of the mind. Your words define your perceptions. They define the way you view things, all right? When I was in India way back when, and then I first went to India probably before some of you were born, 1971, right? I met this guy that had been silent for 20 years, and he wrote on his chalkboard one day, "If a pickpocket meets a saint, all he sees are his pockets." Pretty profound. Anyway, that's the effect. So motivation affects perception. Anyway, so fear via the HPA axis increases cortisol, adrenaline, noradrenaline. It modulates cytokine production. It alters the gut microbiota. All of those things suppress the immune system. We also have decreased serotonin, dopamine. We have increase in histamine and other intermediates, okay, resulting in decreased maturation of macrophages and dendritic cells, which means we cannot activate the naive T cells. And if you can't activate them, you cannot initiate the immune response. All right. We also see that the ILCs and the gamma delta T cells decrease cytokine. They don't have enough cytokines to initiate the immune system. All right, the immune response. All right. So this happens from fear. Fear, anger, regret, any of those things will impair immune function. And the reason this is so important is because we have to be very careful what we say to our patients. All right. Now, why don't I use the word? Oh, is that it? Where was it? Oh, there it is. Okay, there. So now we have, I showed you, we have chronically fermenting cells, and that's what I'm going to call them. When I talk to my patients, I don't say you have cancer, because what does cancer mean? If you look up cancer, you try to define that word, you're going to find it means people that were born between June 22nd and July 22nd, period. That's what it means. It has no other meaning. Therefore, when I use that word, what do I convey? I don't convey information, I convey fear. I just told the person they're going to die, because the word cancer has become synonymous with death. So when you say that word, you have just stolen their future. You have made all of their agenda, all of their plans irrelevant. Okay? You talk about traumatic stress syndrome. There it is. That's traumatic stress. Okay? You just told some person they're going to die if you use the word cancer. So the word cancer conveys no information. However, if I tell them you've got some chronically fermenting cells, and the reason they're fermenting is an adaptive response to an accumulation of toxins in the environment, the interstitial fluid, that knock out 30% or more of the mitochondrial function. Once that happens, we got to change operating systems. We got to go from Mac to Windows because it's not working, and that's what happens. Therefore, once I understand that, I realize, well, then I can develop a strategy to resolve it, because now I have information. I have communicated information and no emotion. There's no emotion. If someone says I have CFCs, I say, okay. But if you say I have cancer, okay. So I'm just telling you how important that word is. I insist that they use this word. I don't call it that word. In fact, when I say the word cancer, it hurts me to say it. Okay, now. In spite of all this, conventional world says it's somatic mutation. And they say that cancer is a genetic disease involving nuclear mutations and oncogene. Nonsense. It's been proven over and over again that that's not the case, okay? However, the NCI in the United States still says cancer is a genetic disease that is caused by changes in... Nonsense. Now, Thomas Seyfried has done these incredible things called Cybrate experiments. Okay, so the normal cells with normal DNA and tumor cells with tumor DNA, and he said, if I switch them, let's see what happens. Well, if I put a tumor DNA into a healthy cell, of course it's going to become a tumor because it's a genetic disease. That's not what happens. So now I put the healthy DNA into a tumor cell, and what should happen? It should be healthy. That's not what happens. Okay? It's not a genetic condition. Now, there was a meta-analysis done, published in 2005, where they looked at multiple studies, as you know, in a meta-analysis, clinical studies in Australia and the USA, and they wanted to see what would happen. Stage 4 CFCs enter into the system. They go to the hospital, and they do everything like good little boys and girls, and what happens? What's their prognosis in 5 years? In Australia, they have a 2.3% chance of being alive in 5 years. In the USA, they have a 2.1% chance of being alive in 5 years. Therefore, they have a greater than 97% chance of not being alive. Now, let me ask you a question. If I told you the airplane you're going to get on has a 97% chance of crashing, are you going to get on it? I don't think so. All right. Now, metastases account for about 90% of CFC deaths. Not true, actually. Most of them are a result of what they call treatment. However, those that are left over, 90% are due to metastasis. And metastasis is a succession of 6 individual steps necessary. By the way, in animal models, 0.01% of circulating tumor cells, CTCs, develop into metastasis, which is why liquid biopsies are nonsense. They make a lot of money for the lab, and they lead you down a path that is ridiculous. Because if I'm looking at my CTCs, my circulating tumor cells, and I do any kind of studies on them to decide how I'm going to treat the patient, I have a 99.9% chance of getting cells that are irrelevant, that are not capable of metastasis. All right. Now, I'm summarizing a study. Paradoxically, chemotherapy actively produces CFC progression. Now, although the chemotherapy, high-dose chemotherapy, what they call maximum tolerated chemotherapy, why maximum tolerated? Any more and you're dead. Okay, so, if they give you that, yeah, the best case scenario will shrink that tumor so it's undetectable. But what happened? We just ensured that we're going to either have the tumor come back either in the original location or in distant metastasis. Okay, so chemotherapy induces changes that favor CFC progression. Okay, through upregulation of the expression of anti-apoptotic genes, increase of the ability of CFCs to migrate. Okay, extrinsically, it affects the non-CFCs, the normal cells, and it also improves the microenvironment so that when that cell arrives at the tumor microenvironment, it's got a good nest. Plus, the body starts producing factors. Anyway, that's how it happens. Here's the steps for metastasis. And chemotherapy enhances all of them, changes the tumor microenvironment, promotes epithelial to mesenchymal transition. The reason that's so important is we all know that only the stem cells can metastasize, right? Okay. Now, we have a mature cell, because we're talking about carcinomas now. Carcinomas versus sarcomas. Carcinomas, a mature cell is an epithelial cell. A stem cell is a mesenchymal cell. So what does chemotherapy do? It helps change it, an epithelial cell, to a mesenchymal cell. So now it can metastasize. It produces CFC escape from the tumor. It promotes immune system escape, so it's able to escape the immune system. Chemotherapy increases circulating tumor cells, and it promotes a favorable microenvironment. Here's a study. I don't have there it is. It was published in 2011. Okay, chemotherapy enhances metastasis formation via VEGF expression in endothelial cells. Bottom line, that's what happens. It induced tumor-promoting changes in the microenvironment. The middle there, you'll see pre-treatment with cisplatin and paclitaxel significantly enhanced lung metastasis in this model. The data indicate the chemotherapy-induced expression of VEGF-R1 on endothelial cells can create an environment favorable to tumor cell homing. Okay? Cyclophosphamide, a very kind of one of the older chemotherapies, expands the population of myeloid cells in the bone marrow, which contribute to skeletal metastasis. Paclitaxel, originally ovarian, then breast, and now it's used in colon, whatever. Anyway, what does it do? It increases bone marrow-derived cells that accelerate metastasis by inducing matrix metalloproteinase 9 expression and EMT, epithelial mesenchymal transition. Paclitaxel stimulates breast CFC metastasis in a toll-like receptor. Okay, that's what it does. Chemotherapy exacerbated breast cancer metastasis, a paradox explainable by dysregulation of adaptive response. Published when? In 2018. It stimulates the tumor-associated macrophages, which promote CFC progression. What is a TAM? When the macrophage enters the tumor microenvironment, which is hypoxic and very acidic, it changes and it becomes what's called a tumor-associated macrophage. So instead of taking a bite out of the tumor and presenting it to the T4 cell, it actually starts doing things that will help the tumor grow. So it's like a spy that becomes turned, right? So that's what happens. It increases TAMs, right? It also increases TANs, neutrophils. And the fibroblasts, which are in the cell, in the area there, the tumor, the nest, now they're called tumor-associated fibroblasts. They start working for the tumor also. They put a fibrin coat around the tumor so that the immune system can't recognize it as other than self. Paclitaxel, gemcitabine, cisplatin, and cyclophosphamide, all standard. They create a favorable tissue environment for CFCs to colonize. So chemotherapy exacerbated seeding in the breast, prostate, colon, anything. What does it do? To the microenvironment, it increases NF-kappa beta, which is inflammation. Increases TAMs, not good. Increases VEGF. Increases HIF-1 alpha, which we know is how the whole proliferation and angiogenesis goes. Okay, all of these things increase the PI3K and the mTOR pathways and all that. And then on the bottom there, WNTs, all of these are necessary for metastasis. It changes those in the tumor microenvironment. So when we're treating someone with cancer, and we find that we either get to the point where the tumors are not going away or they're growing, there's only one of two things that are happening. Number one, we didn't get all the toxicities that are causing it in the first place. And number two, we haven't changed the tumor microenvironment, because I don't care how good the immune system is, once it arrives at that tumor microenvironment, it gets wiped out. Just to remind you, how important NF-kappa beta is? Yeah, pretty important. How about HIF-1 alpha? Yeah, pretty important. These things are turned on with chemo. Now, as you know, the toll-like receptors are how antigens are recognized. It's overexpressed in 68% of breast CFCs. All right. Basically, I wanted to get down here to the bottom. The TL4 is a novel determinant of response to paclitaxel in breast cancer. All right. So, in other words, this is upregulated by paclitaxel. This is who doesn't use paclitaxel? Almost every solid tumor is treated with that. All right, so, and then again, I'm not going to go into all this, but I just want you to know, it also inhibits natural killer cells. Now, one last thing I want to show you is this, that the chemotherapy induces tumor immune evasion by upregulating the programmed cell death ligand expression in bone marrow stromal cells. Why is that important? Because, I don't know how many years ago now, 10 years, 15 years, whatever, in conventional oncology, there was an announcement. There's a revolution in treatment for cancer now, for CFCs. That revolution is called checkpoint inhibitors, oncoimmunology or immuno-oncology, whatever you want to call it. So here we now know that there is the programmed death cell ligand, which comes from the tumor cell, and then the receptor, which is on the T cell. So the T cells are there ready to kill, ready to eat. But what happens? The tumor cell binds to it, and it inactivates it. So they said, well, hey, let's put in a blocker. Let's block either the ligand or the receptor for the ligand. And guess what happened? It works. Now we freed up the T cells. So this is a revolution in cancer care. So I wanted CFC care. So I wanted to see, is that really a revolution? Let's see how that revolution is. So I looked at it, and I saw, well, with durvalumab, we get 11.2 months versus 8.2 months. With Keytruda, we get 14.9 versus 10.7. Optivo, 15.6 versus. I don't consider these a revolution, because I'll tell you something. If someone's got CFCs and they're going to get an extra 3 months or 4 months, that's not their goal. Their goal is to live out their lives. So I don't see this as a revolution in anything except a way to make more money. Okay? So, but what happens? Why do they fail? They fail because if the tumor is not already surrounded by T cells, it's called a cold tumor. If it is surrounded by T cells, it's called a hot tumor. So clearly, unless you have a hot tumor, putting in these checkpoint inhibitors is not going to help. So how do we convert them? You know, they've got all kinds of drugs to try to convert them, and they're not working. But you know what? There's no slide on this, but you can look it up. Just look it up on PubMed. You know what converts cold tumors to hot tumors? Ivermectin. Anyway, now let's look at radiotherapy, radiation therapy, and let's look at what happens in there. Exactly the same thing. It paradoxically promotes metastasis by inducing epithelial to mesenchymal and then transition. It turns on all of these other factors. It increases. In fact, it's the same thing. Radiotherapy. So here's one study, 2015. Radiotherapy leads to the activation of interconnected series of processes in the tumor microenvironment, inflammation, cycling, hypoxia, blah, blah, blah. Okay? And these are the changes. I'm not going to go over the details down here in the bottom, but you can see that radiotherapy does the same thing. And the other thing it does, induces CFC stem cell phenotyping, okay? So, in prostate CFC patients, radiotherapy increased the CD44 plus cell population that inhibits CSC, cancer stem cell properties. Surgery induces immune suppression. I won't go into details. Cancer cell adhesion. Cancer surgery also results in angiogenesis and metastasis. And anesthesia, which you have to have, is going to, first of all, the anesthesia, it's going to take probably up to 4 to 8 weeks for your liver to eventually detoxify that situation. You have also, which I didn't go into here, you've also produced a wound. That wound is going to cause an inflammation. And that wound, the process of that wound healing stimulates the whole underlying CFC process of chronic inflammation. Okay, so we have to understand that. And by the way, the study done with breast CFCs, the day before the surgery, the day after the surgery, the natural killer cells were cut in half just by the surgical process. Oops. Now, yeah. So what I want to say in this regard is this. Do we ever do surgery? Yeah. What I'm talking about is an integrative approach. We're going to do the best. We're going to take the best therapies from every discipline because no one discipline has all the answers. All right? So for example, if your baby is coming out feet first, you're not going to go to the herbalist. All right? You're going to go to an obstetrician. All right? You broke a femur, you're going to go to an orthopedist. All right? You're in septic shock, you're going to go to an ICU. You're not going to go to anywhere else. But you've got to know when to do what, and that's what integrative oncology, integrative medicine, which is now called functional, or people are calling it functional medicine. That's what it's all about. In order to give a patient a true second opinion, because if they go to MD Anderson, then they go to Dana-Farber, and then they go to, I don't know, whatever, three places, they're going to get 3 first opinions. They will not get a second opinion. It's like they went to 3 Toyota dealers. You're not going to find out about the best car to buy from 3 Toyota dealers. To get a second opinion, they've got to come to people like you and I, who not only know the conventional world, but we know the other world. And we can say, in this circumstance, we'll do this, in that circumstance, we'll do this, right? That is a true second opinion. So do we do surgery? Absolutely. I've had people with the bowel is about to obstruct. I've got to do surgery. We've got to do it. Yeah, absolutely. Do we do radiation? Yeah, absolutely. I got a glioblastoma growing quickly in the brain. I've got to do radiation. I can't do anything else. I've got a tumor on the spine. I've got a tumor about to fracture a femur. Yes, yes, yes. Do I ever do it on soft tissue? Never, never, never. Why? Because not only does it not help, it causes problems. I've had people die from adhesions of being unable to eat, got rid of the tumors, they had radiation to their gut, and now they're having adhesions, they get bowel obstructions, and they die from malnutrition. So I'm not going to do something like that. All right? So we have to know when and what to use. That's the integrative approach. And in my second lecture, which I'll do tomorrow, I'm going to talk about what it is that we do. What are the therapies that we can do that are actually going to not only achieve what we hope to have achieved with high-dose chemo and radiation and all that, but we're not damaging and we're stimulating the health of the non-CFC tissues. Why do we need that? Because it's the environment that the tumor is living in, which is called our body, that must be healthy and able to grow and able to allow health to evolve. All right, so if I'm damaging my healthy cells, it's impossible for me to ever heal. All right, I hope I made it in time. I talked as quickly as I could. Anyway, I have a clinic. I have a clinic in the United States. You know, we're in our 20th year, and Oasis of Healing. I live in Thailand now since 2012, and yeah, I've opened up several clinics here. I've helped people open up clinics here, and I do that. Malaysia, and I'm going to be going to India soon and helping somebody develop this part of their care. Bringing CFC treatment. I've wanted to come to India for a long time because very large population. And unfortunately, most Indian people think that the United States is something to emulate. It's not, but unfortunately, they're going to follow the wrong country there, and we're going to see lots of problems. So I want to get us ready to take care of it, because we know that this increase in CFCs worldwide, the vast majority will be in Asia and Southeast Asia. So we've got to be ready.
Thank you. Thank you, doctor. All right. So I think you've beautifully connected various dots that play such an important role when it comes to cancer. And of course, all of these are so less known and so less spoken about. We have a couple of questions. I'll just take them. So, what kind of cancers respond well to a functional medicine approach?
That's a good question. And we have to realize, I don't know why my picture doesn't come on, but anyway, oh, there I am. Okay. Anyway,
Sir, you could, Dr. Thomas, could you please switch off the virtual background if that's a possibility?
how
You
do I
can
do
go to
that?
the video settings,
Yeah.
click on the small little arrow, and you can choose to remove the virtual background if that's a possibility for you.
I see Sony camera, blur my background, adjust, choose filter.
Choose a virtual background. You can go to choose virtual background, and you go to the background and effects.
You go to video settings. When you click on
Yeah,
video,
I'm there. Oh,
Perfect. Thank you very much. Thank
I
you.
don't know what happened. Okay, very good. So that's a good question, and I'm glad you asked it, because there are not different kinds of cancer, CFCs. All right, the fundamental biology of CFCs is aerobic glycolysis. That's it, and it doesn't matter where it is. And the only difference is location. So when they say I have a rare cancer, no, the location in which it began is rare. However, the process is the same. So, and I'm going to give you an example. Why does pancreatic CFCs, I want you guys to get in the habit of using that word. Why do pancreatic chronically fermenting cells? Because every time you say that other word, you hurt your patients. You knock down their immune system. So be nice to them, okay? Anyway, why does pancreatic have a much worse reputation than others? Because of its location. If it grows 1 centimeter, it's already either in the bile duct or it's in the spleen. It's right there. And so it's already a stage 4. However, I can have a breast tumor that's grown 3, 4, 5 centimeters. It's still stage 2. Okay, so in other words, it's location. If it's in the brain and it grows, we're in trouble. So it's location, location, location. So that's it. So what does functional medicine? It works on all of them, because number one, we've got to eliminate the reason why it occurred in the first place. That's number one, and that's with looking at and by the other thing too. I really have to bring biological dentistry to India. I wish I could do a whole lecture on that, because if you understood that you cannot take care of people with cancer if you do not take care of the mouth, it's impossible. We'll go into that another time. But anyway, so you get rid of that. You have to eliminate the cause. So you look at potential hidden infections in the jaws. You then do complete detoxification with maybe a 3 to 8 week juice cleanse. And you do colon hydrotherapy, lymphatic work. You do all these. You balance the hormones. And number 1, 2, 3, 4, and 5 is you teach them to meditate. You teach them to turn off the mind, because the mind, even though you're using the word CFC and all that, and you're picturing a beautiful mountain, 80% of human thought is negative and 90% of human thought is subconscious. So no matter what we're thinking underneath, it's so the only way you can deal with it is to turn it off, and that's what meditation. You all know that meditation will turn it off. So we've got to be teaching that throughout the day. So all of those things, and then number 3, we've got, and I'll talk about this in my lecture tomorrow, now we have to change the tumor microenvironment so that the immune system doesn't get paralyzed. So yes, it works with all of them.
wonderful. I mean, it's just so nice to hear you. I mean, you're just talking about everything that's so important and not just 1 or 2 things. So there's a question. Can you talk? Okay. Maybe you can just briefly answer this. Efficacy of ivermectin on cancer.
Incredible. And not only ivermectin, fenbendazole, and the other benzimidazoles like mebendazole, albendazole, and niclosamide. My God, niclosamide is now becoming frontline treatment for ovarian and also sarcomas. So why is that? We have to ask that question. Why is that? Well, could there be some parasitic involvement? And the answer is yes. What did Royal Raymond Rife do? Royal Raymond Rife had an incredible microscope. He could see these nano-sized microorganisms, and he just knocked them out with frequency. He had 100% efficacy. And when someone has 100% efficacy, you gotta listen to them, right? Okay. Anyway, ivermectin works for several reasons. Ivermectin, first of all, turns off several of those pathways we were talking about that are required for CFCs to exist. Number one. Number two, it kills the stem cells, so it can't metastasize. I mean, that's amazing, right? And number three, it's getting rid of parasites, which probably are contributing to the whole thing in the first place. So yes, ivermectin is very effective, but I would never do just one. I would never do either like fenbendazole or ivermectin. I would do at least 3 anti-helminthics. I would do an ivermectin, a mebendazole, fenbend, whatever, and then niclosamide. Unless I think I have a liver fluke or anything like that, then I would add in praziquantel. And then I would also do at least 1 or 2 anti-protozoals like nitazoxanide or tinidazole, right? And then and you got to do it. Remember, with parasites, we're talking about biomass. We're not talking about the number of them, because remember, they can lay anywhere from 2,000 to 70,000 eggs a day. And each of those eggs can become from 2,000 to 70,000 new worms. So when you realize that, you say, I took an antiparasitic. Well, you got to do it 3 weeks on, 1 week off, 3 weeks on, 1 week off, and multiple cycles. All right. So, yep, ivermectin, yay.
So, can it also be used as a preventive measure?
Yes. As a matter of fact, if you had CFCs and you cleared them out, then you want to take prophylactic. If you haven't had CFCs, you want to take prophylactic, like I do. So I'll take ivermectin 12 milligrams twice a day. I take mebendazole 500 milligrams once or twice a day, and I take niclosamide once a day. And that way, I want to make sure I don't get that. And yes, absolutely.
Wonderful. So thank you so much, Dr. Thomas. And I think of all the takeaways that we have from your session today, the most important one is let's just start replacing the word cancer cells with CFCs.
Right. Don't scare your patients.
Absolutely. Thank you so much.
Thank you very much.
All right. So moving on to our next speaker. So we all know the power of imaging, how it has always been helpful in reshaping our understanding and management of any disease. And today we'll be talking about how technology, how imaging has helped us in understanding cancer better.